We're going to go ahead and get started. If everybody could take a seat. We appreciate everybody being here today for our workshop. We have 5 great presenters presenting with us today. So each presenter will take about 15 minutes to present, and if there's time at the end of their presentation, we will take questions for another 5 minutes. Otherwise, we will be taking questions at the end of the session if we run out of time. But I'm Terry Schindler. I'm at the University Hospitals in Cleveland, and I'm here with Lisa Padula, and she's at
Laura Padula.
Laura Padula. Oh my gosh. I've known her for like how many years now?
A long time.
She's at CHOP. I know I have that right in Philadelphia. But welcome everybody, and we're going to go ahead and get started. It's our disclosure size and the CF Foundation presentation disclaimer. And these are our session objectives for today. And again, if people didn't hear me, we're going to, the speakers will have 15 minutes to present their research, and they have 5 minutes for questions and answers. So if they have time, we will take questions at the end of their presentations. If they use up their whole 20 minutes, then we'll have questions at the very end of the session if you stick around. So welcome everybody. They're gonna try to dim the lights somehow in here. I know there's a lot of natural sunlight in here, unusual for Seattle. But just so they can see it better, we did ask them to try to make these slides a little bit darker. So I see people wearing sunglasses, kind of fun. Go figure. And then on the app, you can submit questions via the app that we can manage at the end of the talks or at the end of the session. Or there's microphones right here and right there if you want to step up and ask questions. But again, this is going to depend on the time limitations that we have after each presentation. So we're going to start with our first presenter. Dr. Liren Birimberg-Schwartz is a clinical scientist at Hadassah Medical Center, and she's at the faculty of the medical care in Jerusalem, Israel. We're so happy that you came all the way here to join us, and she actually had to tolerate her luggage getting lost, so extra kudos for joining us and being so patient with the transportation system here. But welcome. Yeah.
So good morning, everyone, and thank you for the organizers for the opportunity to present here today. These are our disclosures. So the gastrointestinal manifestations in cystic fibrosis are often the earliest sign of cystic fibrosis. Sorry. Can't see, can't hear, but the view is gorgeous. So let's focus on that for a while. Okay, are we better now? Here, let me try to make this. I can even hear now. Okay. So we'll start from the beginning. So the gastrointestinal manifestations in cystic fibrosis are very often the earliest sign of CF, with pancreatic disorders and meconium ileus being the presenting symptom, coming even earlier than lung manifestations in our infants. And most of our patients suffer from abdominal symptoms, including abdominal pain, steatorrhea, and motility issues, making the gut a significant and increasing important focus in CF-related research and clinical care. So the evidence of gastrointestinal inflammation is gradually increasing. So one example is the study by Dhaliwal et al. That showed elevated fecal calprotectin levels in patients with cystic fibrosis. These levels were higher than the controls, but yet lower than the levels in patients with IBD, Crohn's disease. Werling et al. Performed capsule endoscopies in randomly selected patients with cystic fibrosis and found evidence of inflammation in 63% of the patients with ulcerations and mucosal breaks. And this was in patients that had no clinically overt symptoms of inflammation. So the pathophysiology leading to gastrointestinal inflammation in CF is multifactorial. It all starts with the CFTR dysfunction that leads to thickened mucosal secretions. And then additional factors such as exocrine pancreatic insufficiency, medications, and diet are additional contributing factors for the intestinal dysregulation and inflammation. And as we all know, clinical trials and getting worse? Yeah, I guess the introduction would be okay. Results, a bit more complicated. So as we all know, the clinical trials and real-world evidence has showed a significant improvement in lung outcomes with patients. It's really funny. I'm sorry. Everybody's squinting. And okay, that has never happened to me before.
Seattle never gets sun, so I think they're just...
So we know that the lung manifestations improve in CF, but the gastrointestinal outcomes were only indirectly observed in these studies. I hear noise, but is anything happening? Yeah, we'll wait.
Yeah, maybe, hold on.
Tell a joke.
Do you want to come up, Michael? Oh no, it's fine.
Yeah.
No, it's fine. It's fine. I think we're good. I think we're good. Yeah. Start over? Really? Okay. Remember, you asked for it. Okay. So, as I was saying, the gastrointestinal manifestations in cystic fibrosis are very often the earliest sign of CF. And we know that meconium, ileus, and pancreatic disorders are present even earlier than lung manifestations in our infants. And most of our patients suffer from gastrointestinal manifestations, and this includes abdominal pain, steatorrhea, and motility issues. So, without a doubt, the gastrointestinal manifestations in CF are becoming an increasingly important focus for both CF research and clinical care. So the evidence of intestinal inflammation is increasing. So we have this study by Dhaliwal et al. That showed elevated fecal calprotectin levels in patients with cystic fibrosis. And these levels were higher than the control patients, however lower than patients with Crohn's disease. This study by Werling et al. Performed capsule endoscopy studies in randomly selected patients with cystic fibrosis and found evidence of inflammation in 63% of the patients, showing ulcerations and mucosal tears. And this is with patients who did not have overt clinical symptoms of inflammation. So the pathophysiology leading to intestinal inflammation in cystic fibrosis is multifactorial. It all starts with the CFTR dysfunction that leads to thickened mucosal secretions, and then additional factors such as exocrine pancreatic insufficiency, medications, and diet are additional contributors leading to intestinal dysregulation and inflammation. So, as we all know, clinical trials and real-life data has shown that patients' respiratory outcomes significantly improve on modulator therapy. However, in many of these studies, the GI effect is only indirectly observed with the nutritional gains of the patients that are receiving them. And the improvement in this nutritional status is partially related to the improvement in their lung function. However, a direct effect of the modulators on the gastrointestinal manifestation is plausible, but still remains relatively underexplored. So we hypothesize that CFTR modulators do have a direct effect on gastrointestinal outcomes in cystic fibrosis, most likely or specifically by improving intestinal inflammation. So the aim of our study was to evaluate the impact of Trikafta on the changes in gastrointestinal symptoms, looking at patient-reported outcomes, as well as gastrointestinal inflammation, looking at fecal biomarkers of inflammation, as well as capsule endoscopy results. So for this, we conducted a prospective international multi-center study that included CF patients across 3 centers worldwide: the Hospital for Sick Children in Toronto, Sydney's Children's Hospital in Australia, and the Hadassah University Hospital in Israel. We recruited patients with a diagnosis of CF who were age 12 and older, and of course provided informed consent, either them or their legal guardian. So patients were evaluated at baseline meaning before starting Trikafta therapy, as well as 6 and 12 months after starting therapy. And in each visit, multiple evaluations were done, including medical chart reviews, stool and blood sample collection, capsule endoscopy, an abdominal ultrasound, and GI symptom questionnaires. A patency capsule preceded the true capsule, so there was really 4 research visits altogether. In my talk today, I'll be focusing on the patient-reported outcomes, so the questionnaire results, the stool markers of inflammation, as well as the capsule endoscopy results. But you are more than welcome to hear some more fascinating results by Keith Uy later on this afternoon, including fecal microbiome and metabolite studies. So for the patient-reported outcome measures, we used the GI Symptom Tracker, which is a validated questionnaire that was developed by Quidner et al. In 2015. This questionnaire includes 28 items that are divided into 6 domains. Each domain receives a score, and then an overall score is calculated as well, and then we can interpret that score to reflect the percent impact on the quality of life, looking at minimal, mild, moderate, or severe impact on quality of life. For the stool biomarkers, we looked at the fecal calprotectin levels, which is a widely acceptable marker of intestinal inflammation, as well as M2PK results, which is a marker of cell turnover and inflammation that has been shown to be elevated in multiple situations, including colorectal cancer. In the capsule endoscopy, we looked at motility, that was assessed by small bowel transit time, as well as overt signs of inflammation, looking at visual assessment scores. Since we don't have a CF-specific score that's been validated, we looked at the Louis score, which is a validated score in inflammatory bowel diseases. So, we recruited 35 patients, of which 40% were homozygous for the DELA508 mutation and 60% were heterozygous. And we'll first look at the patient-reported outcome measures. So first of all, none of our patients reported a severe gastrointestinal impact on their quality of life. Most of the patients reported only a mild impact, and the proportion of those patients decreased over the study period, while the proportion of patients with only a minimal impact on quality of life increased. And overall, we saw an improvement in the total score of the patient GI questionnaires over the study period of time. And this improvement was driven by multiple domains, more specifically the GI symptoms, the dietary behavior, and bowel symptoms. So if to summarize what we found from the patient-reported outcome measures, we saw that our patient cohort, most of them reported a minimal or mild impact on their quality of life, but we still managed to see an improvement in the patient-reported outcomes. So we'll then look at the fecal biomarkers. What you see here are 2 graphs that reflect the changes in the levels over time, and the dotted line represents the Cotta value of normal. So on the graph on the right, we see the fecal M2PK levels that we saw that were significantly decreased at 6 months. However, this decrease was not sustained at 12 months. And on the left, we see the results of the fecal calprotectin levels that decreased over the study period and were significantly decreased at 12 months compared to baseline. So we then took the fecal calprotectin levels and characterized them into normal and abnormal using the Cotta value of 80 micrograms per grams, which is the Cotta value of the assay, and it's presented here in purple. And what we can see is that the proportion of patients who had normalization of their fecal calprotectin levels increased significantly. So if at baseline there were 40% of the patients with normal fecal cal levels, at the end of the study we had 86%. So our patients not only improved in regards to the fecal biomarkers of inflammation, they actually normalized in a big proportion of our patients. So now let's look at the capsule endoscopy. So we said we looked at motility and we assessed the small bowel transit times, and we saw trends towards a decrease in small bowel transit times, which reflects an improvement in motility. That is what we would be expected with improved CFTR function. So overall, we had 24 patients who completed the capsule endoscopy studies. And like we said, we used the Louis score for assessment of the inflammation in the capsule endoscopy. And in this score, any value that's less than 135 is normal. Any value that's 790 or above says there's evidence of moderate or severe inflammation, and anything in between is mild inflammation. And what is, most profound, or you can see right away, is that none of our patients had moderate or severe inflammation. And the majority of patients actually had normal findings on their capsule endoscopy. So this is really reassuring from the clinical perspective, but it might challenge a bit of seeing the differences in capsule endoscopy findings in our patients. So we're right now in the process of really looking into the capsule endoscopy results, trying to understand, are there specific characteristics in patients in CF? What kind of drives that inflammation, and what factors can predict that in our patients? But let's start by looking at these 7 patients who at baseline had an abnormal capsule endoscopy. So out of those patients, 6 were pancreatic insufficiency, and only 1 was pancreatic sufficient, and 2 patients were homozygous for the Del 508 mutations, the rest were heterozygous. And if we look at their capsule score over time, we see that the majority, 6 out of 7, had improvement in their Louis score over time and actually had a normal endoscopy score at the end of the study period. The last patient just had a stable endoscopy score throughout the study. And if we look at their fecal biomarkers, we can see that the M2PK levels, which is the graph on the right, overall decreased in the majority of patients, or was either stable over time. But what really is profound, again, is the fecal calprotectin levels, that at the end of the study period, they all had normal levels, even the ones that were abnormal at baseline. So if we take this cohort, this subgroup of patients who had an abnormal capsule endoscopy at baseline, we can see that there is evidence of improved inflammation on Trikafta therapy that was reflected both in the capsule endoscopy and also in the fecal biomarkers. But if only life was that was so simple, we had a subcohort of 4 patients who had a normal capsule endoscopy at baseline and actually developed an abnormal endoscopy score over time. So this really emphasizes that significance of kind of really delineating the factors and looking at the capsule endoscopies of each one of our patients, right? We can look at them as a group, but we know how individualized kind of therapy and treatments are really at the forefront of CF today. So to conclude, we saw that in our cohort, the baseline inflammatory markers, including capsule scores and fecal biomarkers, were relatively low, but we still managed to see an improvement on Trikafta therapy in the fecal biomarkers, GI symptoms, and motility. And these findings really support the potential of Trikafta to reduce GI involvement in CF and hopefully even prevent it in patients that are receiving these drugs earlier on in their lifetime. And we're continuing to do ongoing analysis, like I already alluded to, including more subgroup analysis, microbiome profiles, imaging studies. So we hope that we'll have a bigger story to tell that we'll be able to report soon enough. And I'll conclude by saying thank you to all the participating researchers and the 3 centers that were led by Tanya Gonska, Michael Wilshansky, and Keith Uy. It really is a privilege to collaborate with such people and physicians and researchers. And thank you for your attention. Twice.
We have time for questions and answers. If people want to step up and ask some questions. And also for the people in the back of the room, there are some seats up here. We've heard from the foundation that they're strict about people being in the back of the room here. I think it's a fire code issue. So if you wouldn't mind taking a seat up front, I would appreciate it. There's quite a few in this first and second row here.
Good morning, excellent talk. Barry Stamets from Miller Children's Hospital in Long Beach, California. Quick question, have you looked at a breakdown between small bowel capsules that were normal and abnormal calprotectins by localizing the inflammation in the large bowel, which increases colon cancer risk?
Right. So first of all, capsule endoscopy is not the great test to assess large bowel inflammation, but we are, like I said, I think we have capsule endoscopy results for 24 patients with CF longitudinal at 3 time points. And this is really a significant resource. So one of our main goals is to really look, where are we seeing inflammation? How is it changing over time? How does it correlate with fecal biomarkers? I can tell you, for example, I didn't share with you today, but we saw that there is a significant involvement in the duodenum that we saw in our patients, right? Not yet reported, that would be expected in patients with CF. So I really believe, we still have our work cut out for us, but we hope to have a lot of information to say about that.
Thank you so much.
So it's my pleasure to introduce our next presenter, Amanda Leonard, who is an advanced practice dietitian at Johns Hopkins University and Hospital in Baltimore, Maryland.
Hello, I'm glad that I got to go second. I think you did a great job starting out. Thank you very much for having me today. I'm going to be talking about a BIA study or BIA pilot that we did in our pediatric clinic. I do not have any disclosures. So for a little bit of background, as was mentioned in the session earlier today, BMI has been the standard to evaluate nutritional status in CF for years and years. It is an imperfect measure, and it doesn't differentiate between lean body mass and fat mass. So we really wanted to look and say the landscape of CF, as it's been changing, how can we find other ways to evaluate how our patients are doing nutritionally? There's increased overweight and obesity, and there were a few studies that actually showed that lean body mass is a better predictor of FEV1 than just BMI. So it really led us to believe, what sort of body composition things can we look at in our pediatric patients? There are no guidelines for optimal body composition in CF, although hopefully they will be coming soon from the Strong CF study. But there are different ways that you can look at body composition. Most of them are not feasible in a busy clinic setting. So there's bioelectrical impedance, skin fold calipers, hydrostatic weighing, and DEXA. So we chose to do a pilot with BIA in our pediatric CF clinic. We did the InBody 770 body composition analyzer, and we got a grant to cover the costs. It takes about a minute to complete, with maybe 5 minutes on the front and back end to get the patients into the lab and out, and it's approved for kids ages 3 and up. We opted not to have our 3-year-olds stand on the BIA for a minute, not moving with their arms, so we started in a little bit of an older population. So just BIA, I'm sure most of you know, uses a weak electrical current to measure resistance, estimates fat mass, body fat, lean body mass. And this is the printout, which we do give to our families, but I tend to highlight the skeletal muscle mass is what we focused on. And then mostly what we use is down here is the change so that we can see over time how weight and lean body mass or skeletal muscle mass are changing. So our methods, we identified in preclinic review people that were eligible for BIA, anyone that was over the age of 9, not acutely ill, and then we shared the results with PT, RD, physician, and the families. We had a smaller subset. Our PT group was piloting the Alfred Step Test Exercise Protocol in posters 497 and 509. There's actually a talk about it right now in another session. And this is a measure of exercise capacity. And we thought it would be interesting to see when we measure the exercise capacity, does it correlate with the lean body mass, with the skeletal muscle mass. So if we could do the A-step test and the BIA on the same day, we did for about 50 participants. So we had 85 BIA measures, about 47% were male. We had a relatively high FEV1, median FEV1 of 101%. So obviously this it's a smaller subset of our population. So of those 85, it was 85 tests on 73 people. So we've been able to do a few serial measurements as they're coming into clinic more often. We're adding more data. 50 of those completed the A-step on the same day. And we looked at a couple different outcomes. We chose percent skeletal muscle mass because we wanted something that would, since there are no standards, we figured if we just use the percent, that would be something we could use to compare. And I'll talk later about whether or not that's probably the best option. So interestingly, one of my PTs said that the title of this should say, duh. A-stepped max effort correlates with higher percent skeletal muscle mass. So on the x-axis, we have percent skeletal muscle mass, and then the max effort level for the exercise capacity test. So if you have more muscle, you do better on the exercise capacity test, which does make sense, but it was nice to see that that held true in our population. And interesting to me, although maybe not to those that have looked at body composition in more depth, was that our kids with a higher BMI, so again, this is percent skeletal muscle mass on the bottom, and then ZBMI on the y-axis, is that a higher BMI actually had a lower percent muscle mass. So that in some of our kids that are gaining weight, they're not necessarily gaining muscle, they're gaining fat. So this is another thing that's interesting to follow. We didn't see any association between percent skeletal muscle mass and FEV1 or FEV1 and BMI-Z. So unlike we had a relatively small sample size, and this was really more of a clinical, this wasn't meant to be a big study, this is just sort of what we did in our clinic to see how it would go. But some interesting information. So conclusions, higher percent skeletal muscle mass linked to increased exercise capacity. A higher BMI has lower percent skeletal muscle mass, and not really much between FEV1 and BMI-Z and this percent skeletal muscle mass. So what can we say? So our real goal was to say, can we do BIA in clinic? And I think it is feasible to do in a busy clinic. It does take a few minutes. We did have some issues, logistical issues. It's housed in our PFT lab. So depending on the schedule for the day, it wasn't something that we could always fit in. But we really found that it was helpful for kids to track individual changes. We've had quite a few kids who are trying to lose weight, and they come back to clinic and their weight's the same. But if we do the BIA, we can say, your weight's the same, but look, your skeletal muscle mass, your muscles of your percent muscle has gone up, so that it's really a positive feedback. And we actually had we had one patient who came last week who had gained 11 kilos in a little over 3 months. And it was, he gained a little bit of muscle and most of it was fat. And we realized that he was an athlete who'd stopped working out. And so he had an injury. And he said, wow, I thought it was great that I gained so much weight. But we could say, the weight, gaining weight is not necessarily a bad thing, but you need to be careful of the kind of weight that you're gaining. So I think it was helpful for individual patients. And I think it's a really promising tool for guiding nutrition and PT interventions. We work together when the PT and nutrition would work together based on the results to say where should we be focusing things for our children. Some of the limitations, our sample size was pretty small. And since there are no standards, we couldn't compare to the general population. And as I said, I'm not sure that percent skeletal muscle mass is the right metric. It's the one that we chose because it didn't have to include age or height, as we could just compare them to themselves. And we also didn't do the BIA in people that we were concerned about disordered eating. So this may have skewed, may have noticed from the demographics, we had a lot more males than females. But if we're worried about someone, their weight, we were concerned that giving them data about fat, that they would maybe take the wrong impression. We really tried to focus, when we would talk about it with the kids, we focused just on their lean body mass and the outcomes, and we didn't talk as much about that. So I think there's a lot more research needed, and I think there's a lot more on the horizon. I'm actually very excited to hear some of the later topics, and I think that if we can better understand the relationship between lean body mass and pulmonary functions and outcomes, that would be helpful, and also looking at a wider range of ages and lung functions. Maybe we can broaden out. We started with a smaller cohort in our clinic just to see if it would work. And thank you very much. Talk pretty faster than usual. Any questions? I'm making up for the fact that we had to redo the first one.
We have a couple questions online. The first one is from Juliana Bailey. Amanda, excellent talk and project as always. Would you be willing to share more about how you interpret these results with families, especially in the context of concerns around body image and disordered eating?
That was a good question. So yes, and as I said, we we're very careful. If we're concerned, and I am not an eating disorder dietitian, it's something that I don't feel comfortable dealing with. And my biggest concern is that I'm going to do something to make it worse. So if we had any concern, we would sort of talk about it as a team and we'd say, this person is not a candidate. But we focused on, I would say, do you want to measure your muscle? We want to see how strong you are. We talk about growing tall and strong. And I only circle the muscle part when I talk about it, and when we follow longitudinally. If they ask other questions, I answer them, but I try and focus on, we're comparing you to yourself because there are no national standards. It's not like BMI where you get a number, and we're just going to see how you do. So we did have one boy said, so you're going to tell me if I get swole. I don't know if everyone knows what that means, but okay.
Good morning.
Good
Did you
morning.
have any differentiation between those that are on modulators and those that are not able to take modulators into your weight considerations?
So we didn't. So is your question, are our goals different, or did we differentiate it in the data?
Did you differentiate in your data?
In data, we did not. We just lumped everybody together. That's a good point, though. And I think there's a lot of different ways we could go back and look at this and different things that we could look at. This, again, was our first pass. We were just happy that we were able to get the BIAs done during clinic.
Is this on? Can you hear me?
Yeah.
Thanks. That was interesting. Just one question about the instrumentation. Like, does it make assumptions about sort of like density of fat-free mass and density of fat and that sort of thing to give you the results?
So my answer is yes, as someone, but I have to say that I'm not an expert on that sort of data, but it is has been tested in kids up to 3 and up, and I'm certain that there are assumptions that are made. If anyone, Jessica or Julie, anyone in the audience wants to add to that. And I think that I don't think that this is necessarily the most accurate. Our goal was to get something just to say, okay, here's where you were, and say a trend, and we're not making any really important decisions based on that. It's almost like a motivating and helping to get them to exercise more.
Yeah, I think I could see how it's really beneficial, especially if you're saying about longitudinal
Yeah.
following up, saying like, how does it change? Not necessarily maybe at this point, like, is this an actually very accurate measure? But yeah, I was just wondering because I didn't know if there were, like, if it had, is there differences in the density and then like how you would make those assumptions in the case of CF?
So there could be, but we didn't.
Yeah. Thank you.
You're welcome.
Another question here from Ann Lanther. Any more information about funding the purchase of the BIA machine for your clinic?
So we have a grant. We applied for a grant through the Hopkins Children's Center. We do like a radiothon, and you can apply for a grant through that. So it's a one-time grant up to a certain amount, so that it's not continuing. So there's very little continuing cost once you purchase it, but that has to be covered by the department. But we were lucky to have that opportunity. So maybe someone else wants to, I don't know, some company can start some grants.
And then from Bridget Doyle, kind of going off of Julianne's question, do you worry about using BIA leading to hyperfocus on their muscle fat and disordered body image in the pediatric population, even in someone who never indicated a concern in the adult world? So pure curiosity.
Yes. So, we try to mitigate it or limit it as much as possible. And I also try and only give the kids and the families the information that they ask for. So I tell them it's going to measure your muscle. I show them it measures, I said, this is where the muscle is. And one of the things on the printout is it shows if they have like an athletic build, that's more muscle versus fat, or a less athletic build where they have more fat versus muscle. So we might talk about that a little bit. I ask them if they want a copy of the printout, which I find to be a little bit overwhelming. And some people want it and they really want to look at it, and some people are, nope, that's fine. So I try and meet them where they are, and also just to be cognizant and, so I guess maybe not focus on the fat part, or the percent body fat part. I'm not withholding it. I just don't want I don't want them to think that's our focus.
And just one final question. Do you take into account pubertal status? Because I know we still have some patients that have delayed onset of puberty, and how that might be affecting their change over time.
No, that's lots of good questions, lots of good things to think about. No, we just sort of, we took our group and we looked at it, and I think that's something else that we could look at in more detail in the future as we're getting a little bit more longitudinal data, which is nice.
Another question. How do you balance discussing expected body changes in children who are growing in all directions pre-puberty in the context of scans?
And by in all directions, you mean up and out? Is that, yeah. We focus, I try and focus, and I think it was Virginia Stallings that said grow tall and strong. I don't know if you those remember, is where years ago, I got that. We focus about that you want to be tall and strong. And so we don't necessarily focus on body size, just linear growth and power. So I think maybe I don't focus on different sizes. And I frequently tell kids, if their name is Joey, that you're the perfect size for a Joey today. Like, I really want them to know that they are how they should be, and that we're just sort of checking on things, trying to make them the healthiest Joey they can be, but that they don't have to fit in a little box.
That's awesome. And a question about whether or not you can bill for BIA interpretation?
I don't know. I don't.
Has anybody been able to bill here?
Yeah, does anybody do by BIA and bill for it? Okay.
Right. Good point.
Okay. That's actually, well, it's good to know, then I won't bother looking into it.
Will the patients get billed though if it's not getting covered?
Oh.
Okay.
So for those of you that couldn't hear, you can bill. It doesn't get reimbursed. And then Terry's question was, do the patients then get billed? And the answer is yes, maybe with private insurance. So for us, it's something that's included just as part of the clinic visit. So it's not something we bill for separately. That was it. Thank you.
And we have one more question. Would you consider doing a muscle ultrasound like quadriceps?
I have not considered that. Some of the other dietitians at Hopkins have. If it was something that I was trained how to do, I mean, I think so. Is that something that you're looking at, Jessica? Okay. So with adequate training, I would be happy to do that.
But do you want to repeat what she said?
Oh, so Dr. Alvarez said that they're looking at quadriceps ultrasound. Is that what you? And bicep ultrasound as part of the strong CF, trying to figure out, and this the best way to look at body composition in clinic, and which really was why we looked at this too, as we thought BIA was the one that we thought was, with the grant, was doable to give us something to have a longitudinal information. Oh, there's my references. I clicked it ahead by mistake.
Did you want to add anything else to the other question, Jessica? I can't remember. Somebody said maybe she would. It's okay. Did we get everything? Oh, one more question.
Okay.
Somebody else asked, what about kids who are truly obese and talking to them and their parents?
So actually the kids that are obese, I find that this is the most helpful, because we can say that you are where you are today. Look how much muscle you have. Why don't you talk to Holly or Karen and Sean, our physical therapists, and see how we can build more muscle so that we focus. We've had quite a few kids that came in and they were able to increase their muscle even though their weight stayed the same. So that, and weight loss might be the end goal, but I think in the interim, increasing your percent muscle mass is not a bad thing. And it gives us something. I've been doing CF for a long time, and for so long, I loved that we never had to tell people they couldn't do anything or that they couldn't eat anything, and now it's all changing. And so I love having something I can focus on, that this is something to add to. Although what Jess said this morning, focus on the add tos, but I think that's something they can add as more activity to help make their body composition the healthiest it can be. Okay. Thank you very much.
Is that it?
I'm glad they.
Thank you. Kind of glad you talked fast, so we had time for all the questions.
I was trying to figure out how to clear that so we could.
And for the people standing in the back, we do have seats up front. If you wouldn't mind taking a seat up front.
So next, it's my pleasure to introduce our next speaker, Dr. Christine Hatcham, who previously was a professor at medicine at St. Louis University and is now an adult gastroenterologist at Intermountain Health in Salt Lake City, Utah.
Okay. All right. Thank you.
Good morning. Can you guys hear me in the back okay? Great, thanks. All right, thank you to the moderators and to NACFC for inviting our team to speak about our study, non-invasive stool evaluation of colorectal cancer and CF. My objectives today are that we recognize that there is an increased risk of colon cancer and CF. We'll discuss etiology and risk factors for colorectal cancer and CF and compare potential options in screening for colon cancer and CF. So the good news, everyone has heard that survival in CF is improving. With that, we see an increasing adult population. Now the median survival age is 65 years. So with improvements in therapies, likely due to CFTR modulators, patients are living longer. And with that, unfortunately, we also see increased risk of cancer. I'll be focusing on GI, but you can see other cancers are increased as well. So this is a picture of a, let's see, is there a pointer? No. Okay, there you go. So you can see just what we see when we do colonoscopy. We see a normal colon is very smooth. When people start to develop precancerous lesions, you see these polyps, and they can grow in size and different pathology and lead to large polyps, which can unfortunately lead to colon cancer. This is an example of a post-transplant patient. She was in her 40s, and we found a 8-centimeter fungating, partially obstructing mass in her right colon. And why is there an increased risk of colon cancer in CF? Well, from mice data, we know that CFTR is a tumor suppressor gene in the GI tract of mice. So the loss of CFTR results in GI tumor formation, leading to dysregulation of the immune response, intestinal stem cells, and growth signaling regulators. With that, you get stagnant mucus, bacterial overgrowth, and then dysregulation in the gene expression and epithelial homeostasis and inflammation. What are some risk factors for CF-related colon cancer? Just like in the average risk population, we do see men are at higher risk. We see a severe functional CF genotype is at higher risk for colon cancer, specifically the F508 delta homozygosity. A history of DIOS, which is distal intestinal obstructive syndrome. The high-fat diet that we've encouraged our CF patients to partake of in the past. And then if you're lucky enough to be over the age of 30, and you've had a history of lung transplantation, those are all increased risk factors for colon cancer. And unfortunately, nearly all colon cancers in individuals with CF are diagnosed before the age of 50, and the majority of these appear to be right-sided. This is one of the pivotal studies for colonoscopy in CF. This is from the University of Minnesota, and you can see they did screening colonoscopy at age 40. This is actually even before the guidelines recommended this age. They found adenomatous polyps, those precancerous polyps I showed you in the colon, on initial screening. Again, these are asymptomatic patients in almost half of the patients. And 25% had one or more of those advanced adenomas, like those little polyps that looked a little bit bigger and uglier. And this is 5 times higher than the general population. And the majority had more than 3 of these precancerous polyps, and 3% had colon cancer on index colonoscopy. Again, these are screening, asymptomatic patients. Even if they had a negative initial screening colon, if you followed up within 49 months, almost half, again, had these precancerous polyps, and half had those advanced adenomas. So it's not surprising that in 2018, guidelines came out for CF colon cancer screening. If you were an individual with CF and you had not had a transplant, the guidelines suggested screening starting at age 40. Even if it was a normal colonoscopy, you were recommended a repeat within 5 years. If it was positive for some findings, you would repeat based on the findings or at least within 3 years. If you had a transplant, the age started at age 30. Again, same kind of guidelines. If they were negative, you would repeat in 5 years, depending on findings, at least within 3 years. So why the NICE-CF study? Well, we know that stool-based testing is done in the average risk population, so FIT and multi-target stool DNA, and we thought it could be valuable as a first-line test for colon cancer screening in CF, but had not previously been evaluated. We know that the prep is hard, whether you have CF or do not have CF, and we know that CF is high risk for colon cancer. And colonoscopies are high risk in CF and difficult to schedule. And look at some of our registry data. We know that a lot of our patients are not being screened. This is 40% screening rate. So of the 3,354 people screened and in the registry over this 4 years, 60 colon cancer cases were found. Again, these are asymptomatic patients. So our study was looking at non-invasive colon cancer evaluation in CF. And you can see here, this is a team effort. There's a lot of the people involved in this study here today. And our study was an observational study. The overall goal was to determine the test characteristics of each stool-based test compared to colonoscopy, the gold standard. Our goal was a cross-sectional, non-invasive observational study. We were hoping to enroll 350 participants because we knew some would drop out due to incomplete stool samples, missed colonoscopies, or inadequate bowel prep, with a goal of 226 with both a multi-target stool DNA followed by a colonoscopy, and more than 204 with a FIT test and colonoscopy. Our primary endpoint was any adenoma, so anything that could develop into cancer, polyps and cancer. We wanted to look at negative predictive value as well as sensitivity. Our secondary endpoints, usual ones, specificity, positive predictive value. We also measured feasibility and clinical outcomes, such as how often did our patients have adenomas or advanced adenomas or colon cancer, the prevalence of sessile serrated lesions, which are another precancerous polyp type. How many of our participants completed stool-based testing? How many could complete colonoscopy and stool-based testing? And how good were our multi-target DNA and quantitative FIT tests in detecting this primary outcome? We also surveyed many of our participants on ease of stool sample collection and colonoscopy prep. Again, this is a team effort, 26 participating sites across the U.S. I've listed some of the PIs and lead RCs, but it's a team effort at each of these sites. So you can see this is the CF registry in terms of patient population, and we try to mirror this with our study, enrolling sites across the U.S. This was our study design. Patients were enrolled either clinic or remotely. They underwent surveys. They were given stool kits too, and stool sample surveys. They underwent colonoscopy within a year, and we looked at the results. This team of 26 centers was able to consent 389 participants. 362 were enrolled. As you can see, we far surpassed the numbers we needed. 254 had both a stool sample and both multi-target stool DNA and FIT. 269 had multi-target stool DNA followed by a colonoscopy, and 278 had a FIT followed by colonoscopy. You can see we did lose some people from not completing stool samples, or the stool samples were not usable, or they did not complete a colonoscopy. Our demographics, mean age, 47. The majority of our participants were over the age of 40, although we did have some that were under 40. The majority have not had a transplant. And as you can imagine, the majority were on CFTR modulators, equal distribution between genders. Looking at demographics, race, as with the CF population, the majority of our patients were Caucasian, but we felt that it mirrored the registry data. In terms of site region recruitment, you can see pretty equal distribution across the U.S. Most of our participants had a copy of F508 delta mutation. Looking at survey data, if you look at this table here, more participants felt stool sample submission was easy, so 1 is easy, 10 is hard, than not. If you look at likely to submit stool samples annually, 1 is likely, 10 is unlikely. More participants were likely to submit a stool sample annually. In terms of colonoscopy prep ease, again, 1 is easy, 10 is hard. There seems to be a wide distribution of participant opinions on colonoscopy prep ease. If you look at likely to complete screening colonoscopy every 5 years, the majority of participants were likely to complete screening colonoscopy every 5 years. 1 is likely, 10 is unlikely. As you can imagine, most of our participants felt stool sample would be ideal over colonoscopy for colon cancer screening. Let's look at the prevalence of lesions on colonoscopy. So remember, our primary outcome was adenomas, advanced adenomas, or colon cancer. This is our prevalence, 45%, which mirrors the CF population data that we have from prior colonoscopies. I give you this column, which is a New England Journal study from 2014 of 10,000 patients, an average risk population. You can compare the outcome in the average risk population and our high risk population of CF. In terms of those advanced adenomas or colon cancer, you can see 13% versus 8% historical control. Our population was probably not enough to capture enough colon cancers, but you can see here. Let's look at the outcome by CFTR modulator status. Again, you can see our primary outcome of adenomas, advanced adenomas, or colon cancer. You can see similar prevalence, whether they were on modulators or off. In terms of advanced adenomas or colon cancer, they're a higher prevalence if they were off modulators. In colon cancer, again, probably not enough data to compare. Let's look at our FIT results. So when you look at the primary outcome, focus on this column, adenomas, advanced adenomas, or colon cancer, our sensitivity is quite low at 0.11. Negative predictive value is also low at 0.55. Specificity is a little higher. Advanced adenomas or colon cancer, our study was not powered to look at this outcome, but you can see sensitivity is 0.24, negative predictive value of 0.89, and specificity of 9.4. Looking at multi-target stool DNA, again, our primary outcome was adenomas, advanced adenomas, or colon cancer. Sensitivity, again, 0.27, negative predictive value 0.58, positive predictive value 0.59, and specificity of 0.84. Numbers are a little bit better in this column of advanced adenomas or colon cancer, but still quite low and not powered. When we looked at outcome analysis by different categories, such as age, less than 40 or greater than 40, prior transplant status, prevalence by sex, or CFTR modulator status, I would say that our outcomes prevalences were similar. So our stool-based testing analysis results show low sensitivity, so high false negative, and low negative predictive value. It did confirm adenoma rates seen in the CF population, that higher number than the average risk population. And we saw similar prevalence of adenomas, advanced adenomas, and colon cancer, comparing patients on and off CFTR modulators. So I hope I've highlighted that in terms of screening for colon cancer, remember that CFTR mutations play a role in GI cancer. We considered it a hereditary colon cancer syndrome, much higher risk for colon cancer in people with CF. So one of the questions we asked, of course, is should all patients with CF be screened for colon cancer with colonoscopy as per the guidelines I showed you from 2018? We'd say still yes at this time. Stool testing cannot be recommended in CF based on our study data results. Our study is the largest study to evaluate stool performance characteristics in high-risk CRC population. We've demonstrated low sensitivity and negative predictive value, and we cannot recommend stool tests for adenomas, advanced adenomas, and colon cancer screening in the CF population. Too many are missed. So colonoscopy is still a critical part for colon cancer screening in CF. Future directions, I don't think the questions are completely answered, right? Should we look at other tests for colon cancer screening? Recently, a blood test came out. Should we try for a larger study powered for only advanced adenomas and colon cancer? I think I showed you that one study. It was 10,000 that they recruited looking at really stool tests for colon cancer. The most recent 2024 New England Journal study recruited 20,000 participants. We can't do that in CF, though. Should we repeat a study in higher risk CF patients, maybe look at only those CF patients that are even higher risk than what we think for general CF? Should we consider different cut points or different genetic markers? Our stool-based testing that we use, the FIT and the multi-target stool DNA, were cut points based on the average risk population. And the question is age 40 the right cutoff? I'd like to thank St. Louis University, my sponsor, the CF Foundation grant, Digest, for really inspiring GI doctors to get involved in CF, our SLU research team, the SLU CF Center, Dr. Nyack and Dr. Barrios and team, our co-investigators, Dr. Friedman, Dr. Schwarzenberg, the DCC, Karen Hinckley, Stokowski, Erica, William Tressel, Cien Joyet, and all of our CF site investigators, RCs, and teams. I'd especially like to thank Michelle Bayless, one of my former fellows who created this amazing logo combining colon cancer and CF colors, and my husband, Ramsey Hashem. Thank you.
Thank you. We'll take any questions, but I have a quick question. We do education with our patients as dietitians, not only screening who still needs a colonoscopy, but why they need it. So it's very helpful to know that these alternate tests are not really appropriate for CF, but sometimes I get pushback from adult providers about patients who are pancreatic sufficient and that they're not as high as risk as patients with pancreatic insufficiency. And if you know of any data to say that that's true, or if the screening guidelines should be different for that category.
I'm not aware of any data that shows that pancreatic sufficient or insufficient have different guidelines for colon cancer screening. If that's your question.
Okay.
I shouldn't. Yes.
Hi, Michael Wilshansky, Jerusalem. The last question about the age. Do you think we should lower the age?
There's definitely some opinions that we should lower the age. And obviously, people are anecdotally seeing colon cancer, even younger patients. I had a personal anecdote of a patient who was 40 and already had metastatic colon as well as small bowel cancer. So I think that is a good question. I don't think we have enough data to support lowering, but we'll have to look at the data over the next few years.
So it's age 40 for general population now, right? Like 40 or
45, yes. And even in the average, we are seeing a lot of young colon cancer just even in the average risk general population. So something is going on that we're seeing younger colon cancers, and they're often still asymptomatic. So you can't wait for symptoms. It's too late.
We have
We have one question. Any thoughts on if CFRD associates with colorectal cancer risk?
I think that there seems to be some association. Again, we don't differentiate our colon cancer guidelines screening based on other factors other than family history of colon cancer, family history, or personal history of polyps, et cetera, but not if you have diabetes or not. Go ahead. Yes.
With patients with fibrosing colonopathy, are recommendations on screening any earlier or still 40?
I don't think there's enough data. And actually, we're not seeing as much of fibrosing colonopathy since we've really educated people on proper enzyme use, et cetera. So I just don't think there's enough data.
Thank you.
And then we just have a comment in the app, not a question, but this is great data. As my adult CF patients often ask to do the stool kit screening test. Thank you for sharing.
Thank you very much.
Thank you. Thank you.
So our next speaker is Dr. Melissa Putnam. She is an associate professor at the Harvard Medical School and an adult endocrinologist at Mass General Hospital in Boston.
Thank you so much. I'm excited to be here on behalf of our Strong CF study group, seated right in the middle right there, to tell you about the results of preliminary data for baseline results of body composition in adults with preserved lung function who have been enrolled in the Strong CF study. Here are my disclosures. So over the next 15 minutes, I want to start by giving you a little bit of background about why we're doing the Strong CF study and the design and conduct of the study. And then we'll go on to talk about the results of the baseline DEXA, body composition, and some functional measures results that we have in our completed cohort so far, just at baseline. And then we'll go on to talk about conclusions and future directions. And so, as everyone here is well aware, and as Amanda also set this talk up perfectly, thank you, BMI has historically been the gold standard that we use to measure and define nutritional status in CF. And this is because higher BMI has been associated with better lung function. And this graph is data from 2019, so pre-modulator. And you can really see how tightly lung function and BMI are linked in both men and women. But things are changing in this post-modulator era, and we're seeing increasing rates of overweight and obesity. So this is data from 2023, and you can see here on the the right that now really here in the light blue and green, over 40% of people with CF fall into that overweight and obese range based on BMI. And BMI, as we heard earlier, has important limitations. So for one, BMI has limited predictive value at the individual level, really helpful on the population scale, but for each individual patient, it may not be so helpful. And also, as we heard earlier, BMI does not distinguish between fat mass and fat-free mass or lean mass, muscle, bone. Other studies in other patient populations have found that fat-free mass or lean mass is a better predictor of morbidity and mortality. And in the general population, fat-free mass mediates that important association between BMI and mortality. And so clearly now, in this post-modulator era, we need a better measure for nutritional status than BMI. And that's why we're doing the STRONG CF study. And so this study is really seeking to redefine nutrition in CF, to shift focus away from fat and towards lean mass, as we heard Amanda talk about earlier. And so we're looking for alternatives to BMI that will be able to capture this fat-free mass, lean mass, and muscle function to something we can do easily at our quarterly visits, something that's reproducible and responsive to intervention, things that we can use in trials and in clinical studies that are meaningful to our patients and that predict or even impact CF-specific clinical outcomes like pulmonary function. And so as part of the STRONG CF study, we are collecting an enormous amount of information on our patients who are being enrolled. And so we're looking at CGM, of course, because I'm involved and I love CGM. So we're looking at glucose levels. We are doing bone density measures with DEXA. Let me see if I can make this with DEXA right here. That gives us really great measures of body composition right here. We're looking at opportunistic CT scans. So if someone's getting a CT scan for another reason, we're going to look at that, analyze the muscle in that scan. For the gastroenterologist in the room, this is not what you're thinking. This is the sit to stand right here. How many times someone can sit and stand? We're looking at activity measures and how much exercise people are doing. We're looking at anthropometric measures like how our different circumferences. We're looking at skin folds. As Jessica mentioned, we're looking at ultrasound on muscles, biceps and quadriceps, and we're looking at hand grip strength. So many different measures that potentially we can use as tools to guide our nutritional assessments. And for this study, so we're doing a baseline visit. It's very comprehensive, and getting medical history, all of these different measures. And then we're following participants longitudinally over a 12-month period at 3-month intervals. We're doing bone DEXA, bone density, and body composition at baseline 6 months and 12 months. And we are enrolling a total of 300 adults with cystic fibrosis. And we have 2 cohorts that we are enrolling, one with an FEV1% predicted below 60%, and then the other half will have an FEV1 of 60% or above. And this cohort is the one that I want to tell you about today, because we finished enrollment in this cohort with preserved lung function. And so these participants, on average, their age was around in their early 30s, and the majority were white, and about 7% of the group was Hispanic. Not surprisingly, the majority had pancreatic insufficiency, so about 81% for females and 90% for men. The percent predicted FEV1 was very good, in the low 90s for this cohort. And around 90% of these participants were on a CFTR modulator. And then in terms of their BMI breakdown, about 70% of women had a BMI less than 25, and about 50% of men had a BMI less than 25. And then The remainder had a BMI of 25 or above. So this is actually a lot of what we see consistent with what we're seeing in the registry. All right, and so the data that I'm presenting now are the DEXA results from just that baseline visit. And so just as a reminder, the way that we interpret bone density by DEXA is we report the Z-score. And a Z-score is basically a standard deviation. So it's the number of standard deviations above or below a mean for a healthy age, race, and gender matched reference cohort. So basically comparing this group of participants to the healthy group at their same age, race, and gender. And so what we can see in this cohort is that at the total hip at the top, overall, it actually looks pretty good. And the vast majority of participants had their bone density Z-score of above -1. And also just to preface this, to be diagnosed with low bone density, that involves a Z-score of -2 or below. And then we consider that -1 to -2, they're kind of in the at-risk range. And so a majority of participants had a total hip result in that kind of above -1 range at both the total hip and then also when we look at the femoral neck, again, similar. So over 60% of this patient population had results above -1, and only a minority of the participants had low bone density at this site. Now, at the lumbar spine, these results were similar in the women enrolled, where the majority had their BMD Z-scores above -1. But it's so interesting and not what I expected. If you can see here, the 21% of the men had low bone density at the spine. Fascinating. I wasn't expecting that, and definitely something that we're going to have to be looking into in the future. And then we also analyzed their baseline body composition results on the DEXA scans. And so looking at lean mass index, so again, this is a Z-score, so it's comparing lean mass in this cohort to healthy reference cohort of their same age, race, and gender. And overall, the lean mass of above -1, a majority of participants had lean mass above -1. When we look at appendicular lean mass index, which is basically looking at, it's kind of like BMI, but we're looking just at the lean mass in their arms and legs. So this was actually the appendicular lean mass, only about half of this group had appendicular lean mass Z-scores of above -1, which is interesting. And we had recently published a study where we actually found that appendicular lean mass index of all of the measures was a better predictor of lung function in people with CF than BMI. So I think appendicular lean mass is important. Now, when we look at fat mass index, so this is looking at the fat mass, kind of similar to BMI, but just looking at fat mass, we can actually see that, well, this was much more normal. 85% of men and 81% of the women had a fat mass index that was above -1. So we're seeing a little bit of discrepancy here. Can't make any conclusions yet, but so kind of lower appendicular lean mass, but higher fat mass index. And then when we look at percent body fat, so the way that there's multiple different ways to interpret percent body fat, but kind of one cutoff that we're using is a fat mass of above 30% in women is considered to be elevated, or 23% in men. And again, when we look down here at this fat mass index, we can see that a significant portion of this group had a percent fat mass above this cutoff. And in fact, when we looked at those participants who had a normal BMI, and then we looked at their fat mass, their percent fat, we actually found that 68% of the women and a quarter of the men had elevated percent body fat. And so that falls into the category of normal weight obesity. So again, this was surprising and kind of more than what I had at least initially expected. So we also did a preliminary analysis looking at the prevalence of low muscle function and divided this out by sex. And so you can see here hand grip strength. Overall, a very low proportion of our participants in this preserved FEV1 cohort had low muscle function based on hand grip strength. Now, when we look at the 6-minute walk test, this was actually a lot higher. And this also, I think, is surprising and something that we'll need to look into more, that over 40% of the patients in this group had evidence of low muscle function by the 6-minute walk test. But when we look at the short physical performance battery, which measures things like sit to stand and balance, actually our group did great, and none of them had low muscle function by this measure. So to conclude, I think we have a lot of food for thought with these results, and it makes me really excited to get the rest of the results in both the lower lung function cohort and then also longitudinally over time. But what we found here is that this data is giving us a preliminary view on important body composition and sarcopenia components in a population of adults with preserved lung function. And we found trends in low lean mass, especially appendicular lean mass index, and also in trends in low bone density, especially in men, as well as high rates of normal weight obesity in our group. And this is really interesting, and I'm so glad that I'm going after Amanda, because this actually fits with a lot of what you guys saw in a pediatric population with BIA, looking at, fat and muscle. So it's really interesting. And so I think this really highlights how important it is for us to look into these alternative ways to identify lean mass, muscle function, BIA, body composition, all of these things. And we're going to need these tools in this post-modulator era. And I'm also hopeful that results like this will help to inspire interventional studies on how we can improve these outcomes and improve weight gain, muscle gain and functional status in our patient population. And so I want to really give a huge shout out to all of the sites who are participating in the Strong CF study. This is a heavy lift, these visits, all of these measures, and we are so appreciative of all the hard work that everyone has done. I also want to put a plug in because we have 2 more months of enrollment for this study. It's going to end at the end of December, and we would love to get as many more patients enrolled in Strong CF as possible, especially those with lower lung function, especially those in minority categories. So if you have any patients that you think might be interested in learning more about their body composition and doing all of these fun measures, then please refer your patients to one of our participating centers. So thank you so much.
We do have a few questions. Are appendicular lean mass index or the other Z-score interpretations from the DEXA available for pediatric populations?
No, I don't think, no, I should say they are on DEXA, the DEXA body composition, they are to a degree. Those reference data are not quite as robust as with the adult population, but there are Z-scores available. I think the important thing about interpreting Z-scores in pediatric patients is that it really does matter if, so we talked about delayed puberty earlier and short stature. Those can really be affected by that. So we have to keep that in mind too when we're looking at in a pediatric population.
Thanks so much, Neil Emery from Christiana Care. There's some thought that visceral fat mass is more correlated with metabolic syndrome in adults. I'm curious if you're looking at that with all of this imaging and DEXAs and everything else that you're doing.
You better believe it. Oh yeah. Yeah, stay tuned. Stay tuned.
Tom Ziegler from Emory. Really great presentation. Fabulous and important study. You guys are saving blood, it sounds like. So does it make sense to look at, anabolic hormones or resistance to the same, such as testosterone? I know you can't do resistance to testosterone, but testosterone or IGF-1 and IGF-1 levels, which are affected by inflammation and infection, and also, any relationship with these endpoints on insulin resistance
Oh,
markers?
I love that question. In terms of testosterone, we are checking a fasting morning testosterone level in all participants. And I'm so glad that we are, because number one, it'll give us a very good understanding of just the prevalence of hypogonadism in men, but also this low bone density at the spine. It really makes me worried that we're missing something here. So yes, IGF-1, IGF-2, we are not running those right now, but we do have extra serum that we could run later. And then I love the question about the insulin resistance. And so we are actually doing, for participants who do not have diabetes going into the trial, we're doing OGTTs to categorize their glycemic status, and we're getting insulin levels. And so we will actually have a good gauge of that as well, because I think that's important. And we'll be able to look at their continuous glucose monitoring data, their glucose data as well. So I think that'll be really, really interesting.
Thanks for that. That was really interesting. I was just curious because you mentioned at the end the idea of having studies about like interventions that have been done in people with CF to like increase muscle mass. Do you know like what data there are for that? Like, are there other studies that have been done? Did anything work, or do you?
Does anything work for increasing lean mass?
Yeah, like any interventions that worked or showed promise.
That's such a great question. Well, I mean, we do know for people with diabetes that, insulin therapy can improve lean mass. And we know that, like, exercise, any kind of resistance training, that can be helpful for lean mass in general and in the CF population. I think in terms of just like medications, I think we're limited. I mean, obviously treating hypogonadism in men with testosterone, that can help. But I think that one of the reasons that we decided to do Strong was for that exact reason, that if we're going to do those studies, we need the right measures to be able to really understand and identify the ones that are effective. And so yeah.
I guess I was primarily thinking about sort of interventions to do more like physical activity.
Oh, yeah,
And I guess probably it might be too early with ETI and other like highly effective modulators to see any interventions that would try to augment that in the setting of modulators.
Yeah. And I think that the PROMISE data that Andy collected looking at body composition before and after ETI is actually also really interesting too, because it does look like a lot of that weight gain that we're seeing with ETI, that's not lean mass. That unfortunately, a lot of that does seem to be fat mass too. And so, yeah, so I think you're exactly right. This is something that we need to spend a lot of time thinking about.
We're going to take an online question.
Oh, yeah.
Thanks, Melissa.
Go ahead.
Oh, okay. I just wanted to make one correction to Melissa. We do now have robust body composition data.
Oh, okay. Oh, thanks.
Vet Demo, 2023, both based upon the bone mineral density in childhood study. So conducted at 5 sites over 7 years, over 10,000 visits. Those data will be presented for Promise by Marissa Kilberg tomorrow. People have an interest. And one word of caution, for adults, use NHANES reference data. That population is enriched in overweight and obesity. So often our patients don't look more compromised than they are because it's not the ideal reference population. Thanks, Melissa.
Do you have any concerns about the use of GLP-1s due to associated loss of lean mass?
Yes, that's such a great question. So yes, big time. We know that in the non-CF population, that GLP-1s, when you start treatment, you do lose a lot of weight, and a lot of that is lean mass in addition to fat mass. And then if you stop treatment, when you regain weight, that's not fat, that's not muscle that you're regaining. And so it is a huge issue. So when I started GLP-1, especially in somebody with CF, so much of my counseling is on making sure you're getting enough protein in your diet and in doing exercise. And it's not just, physical activity and walking and running. It is strengthening resistance type training. And there have been some studies in the non-CF population that that when you do add resistance training and activity, physical activity and exercise to a GLP-1, it does help to kind of offset that lean mass loss that can occur.
But that occurs with any rapid weight loss.
Any rapid weight loss, but it's the numbers I think are concerning with GLP because so many people are taking them. Yeah, yeah.
Jananne Stallings from CHOP. This has been a great session. Thank you for those who chose, all of you. Partly just as Andy Kelly said, on the pediatric side, we know a good bit about appendicular measurements. It sort of came out of peds because we were measuring whole bodies, back when most of the adult work was on spine and osteoporosis. And then, as you mentioned, the new reference data out that and Andy worked on, I think are available. The overarching thing to say, to keep us a little balanced, anytime you lose weight, you lose both lean mass and fat. And anytime you gain weight, you gain both. So as you were just saying, part of it is how do we, I think the exercise is a key component. Our CF patients in general get twice as much protein as they need. So when you think, not taking apart the GLP-1 story, but patterns change. So I don't think we have to focus on getting in more protein. It's good quality protein, it's there. Every diet survey shows they get, 1.5% to 2%, twice what they need. So how do we start to understand and interpret? And one of the things to think about is watching the kilos of lean and fat, not the percents. The percents are derivative. If one goes up, the other one has to go down. But I do think we have turned the corner from the BMI story, which certainly I helped perpetuate, but it's what we had at the time. And we're doing a great job of what are we going to find out. The only other thing from one of the earlier talks, BIA as a methodology has gotten better again over the last 10 years, but most of its information comes from your height, weight, sex, and age. So whoever asks the questions about hydration or any of those other things, or how to really be very careful in your longitudinal measurements, is going to be important to figure out. But it's clearly better than it was, and I think has real promise.
Yeah, and we are actually doing a BIA sub-study in Strong as well, where we're getting BIA results too. Yeah. I will say a lot of my adult patients that I treat with GLP-1s with CF, even though in general we do try to encourage protein for the CF population in general, a lot of the overweight and obese population, I think we still need to focus on protein because they tend to not eat that same way. So, but I will say I've had very good results using GLP-1s in this population.
Are there any differences in bone mineral density based on CFTR modulator status?
That's a great question. I think we're still figuring that out. There's been initial data suggesting that the Delta F508 mutation may be associated with worse bone density. I think in this post-modulator, era, I think we don't really know anymore. But certainly, having more severe lung disease, we know older age, we know diabetes, liver disease, all of these things, which tend to be worse in those with more severe mutations. Those also affect bones. So I think that definitely can play a role.
And then how much bias do you think there is in patients who choose to participate in this type of study?
That's a great question. It is true. I think a lot of people who are, in the study, it's because they want to know what is going on with their body composition. That said, we tried really hard to get a range of people. So some with low lung function, some with high lung function. And I think that, as you can see from our BMI data, we're not just getting like young, fit people who are interested in their body composition. And in our site in particular, we've had a lot of, little old ladies who would just really want to know. And so I think we are going to see hopefully a representative sample, but it is always a limitation when you're looking at a study like this.
We'll take one more. Were there any data, or was there any data gathered that compared body composition and lean muscle with dietary protein intake?
There will be. So we are getting measures of nutritional intake, and so that's more to come.
Let's see. Wait. We have 1 minute.
One more. Along the lines of what Dr. Stallings had mentioned, I wonder about also looking at your cohort compared to the ESPN fat-free mass index cut points of 15 kilograms per meter squared in women and 17 in men. This might give an added pragmatic view to what's emerging in this study and a way to define prevalence of malnutrition in the cohort that goes beyond BMI.
Yeah, no, absolutely. I think that's what's so exciting about this study is that this was just descriptive. I mean, we haven't even started the analyses, and we're going to be able to look at it longitudinally over time. So trying to decide which measures, which cutoffs, all of these things, that's definitely going to come. So stay tuned.
Thank you so much. For our last presenter, we have Dr. Tanisha Daly, Associate Professor at Emory University, and also a part of the Division of Pediatric Endocrinology at the Children's Healthcare of Atlanta.
I think my slide got advanced. No worries, no worries. Thank you for inviting me here, and good morning or good afternoon to everyone. I have nothing to disclose. And as a pediatric endocrinologist, I think it's appropriate that I go ahead and start talking about CF-related diabetes because that's what I do. Many of you may know that CF-related diabetes is one of the most common complications that we see in CF. And when we look at adults who have CF, when we look at them in their third and fourth decade of life, about 50% of them will have CF-related diabetes. There are multiple reasons that CFRD develops, and this figure that I have up today shows some potential mechanisms that may be involved in the development of CF-related diabetes. One of the first mechanisms that I'd like to discuss is exocrine pancreatic damage. Now, I'm in a room full of people who do CF, so I don't really need to talk that much about exocrine pancreatic damage. But what many of you may not know is that in close proximity to the exocrine ductal cells are the islets. And so as the islets reside in this really toxic environment where exocrine tissue is being replaced by fibrosis, we also are seeing some compromise to the blood flow and the innervation to the islets. And that impairs how they function optimally. Some other contributors to the development of CF-related diabetes are our gut hormones or dysregulation of our gut hormones. Two of the, actually say one of the most famous gut hormone, GLP-1, everybody in this room has heard about that, and GIP can be decreased in some individuals who have CF. And even in individuals who don't have a reduction in their gut hormones, what we find is the incretin effect, which is an oral glucose load allowing for a surge in insulin release, is impaired within CF, which we believe is likely contributing to the development of CFRD. I want to point you guys to the right side of the figure, and I want to talk about genetic susceptibility. And what we know about genetic susceptibility is largely thanks to Scott Blackman and his group at Hopkins that have found some relationship between genes in type 2 diabetes, also conferring risk for CF-related diabetes as well. And so the last thing I'd like to talk about is insulin resistance. Insulin resistance was not something that we saw that commonly as a pediatric endocrinologist unless an individual presented with a pulmonary exacerbation. And this was a time where we saw a surge in the insulin needs and requirements. Fortunately, with the advent of highly effective modulator therapies, insulin resistance is not something that we see as much in the pediatric age group. We do see some insulin resistance if they are on a corticosteroid therapy. And many of our adult colleagues will see this in the setting of overweight and obesity. So we put all of these factors together, and what I want to highlight is that they all lead to the primary defect within CFRD. And that primary defect is an insulin secretion defect, allowing for decreased insulin production. So switching gears a little bit, I just want to also kind of give a very shallow overview of type 2 diabetes and talk about the factors that contribute to the development of type 2 diabetes. Things that we know: excess intake, low activity, environmental factors, and genetics can all contribute to the development of adiposity. And it's that increased adiposity that allows for insulin resistance and the development of type 2 diabetes. And for some, that increases their risk for other cardiometabolic disease. So when we compare type 2 to classic CFRD, and I'm saying that, you'll see why I'm saying that in a moment, we see that there's some differences and similarities. We'll start with some of the similarities. We know that there is some impairment for both with insulin production from the pancreas. Where we start to see some differing is in classic CFRD, insulin resistance tends to be mild, whereas in type 2 diabetes, it tends to be more severe. Features of metabolic syndrome in type 2 diabetes, such as obesity, hypertension, dyslipidemia, it's more common in type 2 diabetes, but very, very rare in classic CFRD. Macrovascular complications are pretty common, and I can never forget in 2016 when I was in the my first meeting of the Envision cohort, Tony Moran made sure that we understood that people with CF do not die from heart disease. So it is very rare that we see a macrovascular disease within CFRD. Classic CFRD. Oh my goodness, the punchline. And then when we look at treatment options within classic CFRD is really limited to the gold standard of insulin. Insulin is anabolic, it helps to increase muscle mass, and that usually corrects the problem. Whereas we have a variety of medications within type 2 diabetes, going back to old school drugs like metformin, and some newer kids on the block like our GLP-1s and our SGLT inhibitors. But the story is not just limited to classic CFRD. We're now seeing this emerging phenotype of CFRD, which is CFRD with metabolic syndrome. And some of this is where we see there's mild insulin resistance in classic CFRD. There's actually moderate to severe insulin resistance in this new emerging phenotype. There's some early data to show that there may be some there is some early data to show that there may be some macrovascular complications within this emergent phenotype, but how common it is and why it's happening is we really don't know the answer to that as well. Our individuals also look more like type 2 diabetics in terms of their obesity and having hypertension and dyslipidemia. And whereas classic CFRD, we're confined to insulin, our Pandora's box has been opened up for us and allow us to use some of these emerging therapies within this cohort. And I think Amir Mohit, if you want to take an opportunity to speak with him, is leading the charge at University of Minnesota in looking at using these drugs in this emerging phenotype. So, stealing your slide. It's important to also talk about the changing landscape within CF. This is actually pediatric data. And again, orienting you to the top of this figure, you can see in the green and the light blue, we're looking at the percentage of individuals who are obese or overweight in the pediatric population. I'm sure it doesn't go unnoticed that there's a bit of an increase that we see between 2019 to 2020, and we all know in this room what happened around that time. And figure is similar for the adult population over this 10-year period. You can see dramatic increases in overweight and obesity in adults over this 10-year decade. So I'm putting all this data together, looking at this emerging phenotype, looking at this changing nutritional landscape, and I'm left with this. Does a higher BMI in CF mean the same thing as it does in the general population? And in order for us to answer some of these questions, I'd like to start off with a trial that was done at our center, who looked at 24 individuals who have CF and 24 controls, and they looked at body composition that was assessed by DEXA and MRI. And what you can see is that in comparison to the healthy controls, individuals with CF were relatively well matched when it came to BMI, lean mass, and fat mass. However, they differed quite significantly in terms of visceral adipose tissue. And the story doesn't end there. What we also found within this cohort was that as visceral adipose tissue increased, so did our fasting glucose levels. And also insulin resistance went up. This really set the stage for the ORBIT CF study. And the ORBIT CF study is an ongoing prospective observational study that's being done at our center, led by Dr. Jessica Alvarez. Preliminary data we started to recruit people and enroll in July of 2019. And the data that I'm going to present to you today includes 32 adults with CF and 14 non-CF controls. Major inclusion criteria, they were 16 and older. They had pancreatic exocrine insufficiency. They were clinically stable, and they had an FEV1 that was greater than 25%. We did not include individuals who were unable to fast, who were pregnant, or who were on steroids. And the goal was to examine relationships that we saw between body composition, dietary intake, and dynamic measures of insulin secretion and beta cell responsiveness. In order to get our data for the body composition and fat distribution, we used MRI to look at visceral adipose tissue, and then we used DEXA data for us to be able to see percent body fat, and which also to be able to calculate our lean mass index and our fat mass index. An oral glucose tolerance test, multi-sample for over 8 time points were also used. And this allowed us to get our data on glucose and our plasma insulin levels. Oral minimal model is a mathematical model, which allows us to estimate insulin sensitivity and beta cell responsiveness from a standard oral glucose tolerance test. Some of the core parameters within the oral minimal model is glucose effectiveness, and that's how well glucose itself promotes its own disposal that's independent of insulin. And insulin sensitivity, it just tells us how effectively insulin can lower blood glucose. And disposition index, which is a product of the insulin sensitivity and insulin secretion. And it just reflects our body's ability to maintain glucose balance despite varying insulin sensitivity. And I put stars next to insulin sensitivity and the disposition index because those are the two measures that we're going to be talking about going forward. We used Pearson's coefficients to be able to evaluate the relationships between these endpoints. Our significance was set at less than 0.05 with 95% confidence intervals. So a little bit about our population. We had a population that was a bit more male dominant at 61% of our cohort are males. The median age was about 28, but what's interesting, it goes from 19 all the way up to 77. The majority of the sample or cohort was white, and majority were not Hispanic. When we look at copies of Delta F508, the vast majority had 1 or 2 copies of Delta F508. Majority were on modulator therapy, and the mean FEV1 was around 75%. What's also interesting about this cohort is about 60% of them were actually had impaired glucose tolerance. So we developed this correlation heat map to really vigorously look at all the measures that we put into this model. And certain things kind of stood out. One was added sugar intake, total sugar, lean mass index, fat mass index, insulin sensitivity, and the disposition index. So the first relationship that I'd like to share with you that we found was the significant relationship between insulin sensitivity and total sugar intake. So as the total sugar intake went up, insulin sensitivity went down. We also then looked at disposition index and looked at that in terms of fat mass index. And similar to what we just showed before, we see that as fat mass index goes up, our disposition index goes down. And again, sorry. We also then looked at insulin sensitivity by fat mass index, and I'm a parrot. I'm repeating the same thing that I've said before, but fat mass index goes up and insulin sensitivity goes down. What I think was a really interesting relationship that we found was a relationship between lean mass index and added sugar intake. Still an inverse relationship that suggests that as sugar intake goes up, our lean mass index actually went down. So, big picture, higher fat mass negatively correlates with insulin sensitivity and the disposition index. Potential implications suggest a favorable sensitivity secretion profile, a less favorable sensitivity secretion profile when we have more adiposity. We also can probably say that higher added sugar intake was not favorable in terms of it actually lowers our lean mass index and our sensitivity. And potential takeaways is whether to see if there's potential value of assessing both diet and body composition to provide some kind of context about metabolic risk within our CF patients. In future, we need more prospective and interventional studies that can clarify these causal relationships and really help us determine if there's clinical relevance to what we're seeing. So I want to thank everyone in the A to Z lab and everyone at the Emory Clinic. I actually feel very embarrassed that I did not say thank you to the Envision program for allowing me to have this opportunity to be here with you today. If had it not been for the Envision program, which brings endocrinologists into CF, I would not be standing here today. So thank you so much to the Envision program. And I'm available for questions.
My name is Pauline, I'm from Germany, and I was wondering while listening to all your great talks, what are the advantages of the different body composition measurements? Because I noticed that you choose DEXA, and we also heard something about DEXA previously, but I was also wondering about like other measurements. So
at our center, we primarily use DEXA, and we also use BIA. DEXA is going to take a lot more coordination and require a lot more resources to execute, whereas BIA, as you heard earlier, it's a really quick in and out procedure. So one of the reasons why one might choose to do BIA over DEXA is the convenience of it. But DEXA is probably a better modality for us to really assess what's going on with body composition.
And do you know if there maybe has been a comparison, or maybe the STRONG study is also going to show that to us in the future? But has there been anything to like what's the best way to use right now, or is that something we're still figuring out?
So I actually don't know if there's an ongoing study that really that looks at that vigorously. I don't know if anybody in this audience knows the answer to that question. Yes, okay. So for those of you who didn't hear, the answer is stay tuned. Yeah.
You want to repeat that?
Yeah, sorry. And from Dr. Alvarez in the front, that the DEXA and the BI correlate pretty well. And the cut points are different. Dr. Alvarez.
I will say, from the clinical end of things, because the DEXA, when our patients get DEXA scans, they can just get the body composition with it. It's, usually part of the package, but our center won't check it because there's a cost associated with interpreting that, and it's not billable to insurance, and so they won't even give us the data, unfortunately. So I don't know how it is at other centers if you've had any luck getting your radiologist to report that, but that's why they won't do it at our center.
Yeah. The body composition is typically on our report, so
yeah, they won't put it on ours, unfortunately.
All right, we have another question.
Catherine Cutney from Rainbow Babies in Cleveland. Thanks for a great talk. I was interested to see the term of CFRD with metabolic syndrome. I wonder if you could expand upon that a little bit. Is that something that you're using in clinical practice? Does it have implications for coverage of different treatments, or where do you think we're at with that?
Sure. So I will say, I will not take credit for that term. It's a term that I borrowed from Dr. Mohit. And I think that's largely derived from his experience that he's at the University of Minnesota, where about 60% of his adult patients are overweight or obese. So, and really that line is blurred for us to really understand the difference between what is classic CFRD versus, maybe a picture that looks more in line with type 2 diabetes.
Thank you. Hey, thanks. That was a great talk. Just going off of actually the other question about sort of like the optimal ways to measure body composition, I saw you in a study, the visceral adipose tissue is measured with MRI. I know you can get it from DEXA. Was there like a reason to do it with MRI, and were you able to get it in everyone with to do the MRIs in everybody?
So I'm going to have Dr. Alvarez answer that question. So slight clarification. This data was visceral fat from DEXA. I thought this was data from the MRI, so I had it wrong.
Oh, are you doing the visceral adipose tissue at all from MRI?
Yes.
Okay, so they have a poster session. Looking at visceral fat from MRI. Yeah. That's what they
Okay. All right. Well,
thank you.
I won't hold you up to get to your lunch.